This is a case of three-port laparoscopic cholecystectomy in a patient suffering from acute exacerbation of chronic alkalosis cholecystitis, having also hypothyroidism, and patients complaining of right upper quadrant pain. Now we introduce the 10 mm umbilical port and 30-degree 10 mm telescope, and you can appreciate well the lever is absolutely normal. And now we are going to introduce the mid epigastric 10 mm port. You can appreciate well the falciform ligament through which we are going to introduce the 10 mm port, and another we will introduce a 5 mm mid clavicular port, and this is our 3-port cholecystectomy. So 10 mm port, mid epigastric port has been introduced, and now you can appreciate the fundus of the gallbladder that is well visualized here. The mid clavicular 5 mm port is going to be introduced, and the pressure remaining 12 mm of Hg, and the flow rate is 9 liter, and patient operated under the spinal anesthesia with sedations. So our first job is the adhesinolysis, and the fundus of the gallbladder has been grasped. You can appreciate that due to the recurrent infection there is adhesions of the omentum, and the undersurface of the liver there is grade 1 fatty infiltration or hepatic steatosis is present. And now the hook is introduced, and adhesinolysis is our first job that is going on, and we are stick to the embryonic plane, which is usually an avascular one, so that the lateral thermal damage and the gut injury can be minimized. So first job is adhesinolysis. Traction and counter traction is going on. So again we are retracting the gallbladder towards the ipsilateral shoulder, that is towards the right shoulder. So again monopolar diathermy hook is an excellent instrument for controlling the adhesinolysis as well as the hemostasis at the same time. You can well appreciate that the stomach and the part of the duodenum is also adhered to these adhesions. So we are doing our job constantly and retracting this fibrofatty tissue from the gallbladder as well as from the liver bed, and with the elbow of this monopolar hook we are retracting our stomach and duodenum away from our operative field. So both the blunt and the sharp dissection can be simultaneously done. Now adhesinolysis from the liver bed is going on. So adhesinolysis is almost done. Some fimbres are there, and cystic duct and the common bile duct can well be appreciated. Just behind this fibrofatty tissue is the common bile duct. So we are retracting the fibrofatty tissue away from our operative field, and you can see the lymph node of Lund or the cystic lymph node. So cystic artery should remain to some extent near this lymph node of Lund. So our anterior calotes dissection is going on. Posterior calotes is almost done. So anterior calote dissection is going on, and small birds means small mistakes. Don't go for a big birds with the monopolar diathermy. There will be chances of injury will be there. So small birds is the main key for proper dissection. Now we are again retracting the gallbladder towards the ipsilateral shoulder, and each and every movement should be precise enough so that no lateral thermal damage is going on. And with the help of this mirror and forceps, we are trying to create a room in between the liver bed and the cystic pedicle. So we are trying to separate the cystic artery, cystic duct, and should remain well away from the common bile duct so that the injury towards the lateral wall of the common bile duct can be minimized and inadvertent clipping can be prevented. So with the help of this sharp tip of this Maryland forceps, we are trying to separate it. Now the bipolar shearer is in and it will do our job to some extent easy. It will make the job so much easy and chances of the lateral damage, thermal damage will be minimized. It is one of my favorite instrument. So again, the adhesinolysis and hemostasis at the same time can be achieved. And with this large jaw, I am trying to separate the cystic artery and the cystic duct, and small fimbrias can be tackled with it. So small fibrofatty tissue that are around this cystic duct has been taken care of. So small pressure and small jaw opening is the main key here, and the fimbriae in between this opening will be cut with the help of the bipolar shearer. Again, we are going to clip it with the help of the 300 Liga clip. So the cystic duct is clipped here. So again we are going to use the 400 Liga clip just distal to this previous one, so that the proper end to end or edge to edge coverage of the circumference of the cystic duct can be achieved with the help of this 400 Liga clip that has been applied just distal to the previous clip. So it is well now appreciated that it is properly applied here. Another 400 Liga clip will be applied distal to these previous two clips, taking a small room for endo scissor to cut it. So 400 Liga clip has been applied here. Now I am going to cut the cystic duct in between proximal 2 and distal 1 clip, and there is a small bleeding from the edge. So there is small branch of the cystic duct. So that has been taken care of with the help of this bipolar shearer. So we are going to introduce the bipolar shearer here, and we are just coagulate the cystic duct has been separated previously. Cystic artery has been coagulated with this bipolar shearer, and small bleeding from the branch that has been taken care of. and this bipolar shearer is an excellent one. It prevents the bleeding from the side, and you can apply the bipolar shearer just to block this bleeding. Sometimes you may not apply any clips, but here I am just going to apply a clip at the cystic artery for double prevention from bleeding post-operatively. Now again the bipolar shearer is in, and I am bipolarized the tissue separating from the liver bed as well as the cystic duct distal stump, cystic artery distal stump, that has been bipolarized with the help of this bipolar shearer. Proximal part I use the Liga clip 300 for sequence of the bleeding. So it's cut, the cystic artery and cystic duct now being separated from their proximal counterpart, and now our job is separation of the gallbladder from the liver bed, which is again an embryological plane, and I am going to separate it. It is a 3-port cholecystectomy, so constant changing of my traction and counter traction in such a way so that the gallbladder fossa can well be visualized. So small birds, and don't go towards the liver, otherwise liver injury may happen and liver sinuses may open up. So small birds, and tip is directed towards the gallbladder always, so that inadvertent injury of the liver can be prevented. Sometimes the gallbladder may be opened up, but it will be manageable. It is better to open up the gallbladder rather than to open up the liver. So it's a dictum. And small birds and stick to this embryological plane will help to maintain the hemostasis and make patients during this separation always changing the traction counter traction. Don't pull the gallbladder too much, sometimes it may torn up from the liver bed and inadvertent bleeding may happen. So small birds is the main thing here. And we will, after separating the gallbladder, we will look after the uterus, fallopian tube, ovaries for their anatomical abnormality present or not, or there is any pathological changes happen or not. So again the camera person is changing the view, and I am separating this gallbladder from the liver bed. These fine streaks of tissues are the fibrofatty things. It's a grade 1 hepatic steatosis. In hypothyroidism, it's almost common in every aspect, and if you going through the LFT as well as the lipid profile, that triglyceride or cholesterol will be raised, and in LFT the alkaline phosphatase, SGOT, SGPT and the GGT will be raised. That means gamma glutamyl transpeptidase will be raised in this kind of patient. And so our gallbladder has been separated enough, and the next job is application of the endobag within it, so that the gallbladder can well be preserved into the endobag, and we will retrieve it. You can well appreciate that it's a spleen that has been shown on the right side of the hypochondrium, that is shown on the left side on this hypochondrium. You can well appreciate that. It can be seen through the 30-degree telescope. It's almost a bloodless surgery. And now our next job is this is the endo bag. Here I have used gloves soaked with betadine. It's my preferred technique of retrieval of this specimen. There is less chance of glaring effect. In transparent bag there is light reflections and it creates some glaring or visual problems. So I prefer to use this white endo bag or gloves as an endo bag soaked with betadine. It will absorb the light and less reflection will be there. So our telescope now has been introduced to the mid-epigastric port, and the gallbladder with the endo bag as a whole will be retrieved out through the umbilical port. So the crocodile forceps is in, or gallbladder extraction forceps is in, and the gallbladder along with the 10 mm port has been retrieved out through the umbilical port, and gallbladder has been positioned in such a way so that there will be no transverse arrest of the gallbladder. So we are trying to retrieve it out with the help of the large curved hemostatic forceps that has been introduced to dilate the tract, and we are constantly taking care of not to rupture the endo bag, otherwise there will be spillage of the stone bile into the abdomen. That's why we are going to use this endo bag. You can well appreciate that through the endo bag wall, the liga clip can well be visualized. So we have to take care of, otherwise there will be a rupture of this of the wall through which the clip can be visualized. So we are suctioning out the bile within the gallbladder after opening it, and small multiple stones are there. So we are trying to retrieve it out. Patient having previous history of the cesarean sections earlier, so you can well appreciate see the scar, and there is some adhesions is also there. Patients having history of the lower abdominal pain and previous history of uterine fibroid that has been removed during cesarean section of and delivery of this baby. So we will check the pelvis after retrieving the gallbladder out from the umbilical port, so that the cause of the pain can be well appreciable after proper laparoscopic visualization. So now small part of the gallbladder is going to be retrieved out. So almost it is done. And just now our job done. The gallbladder has been retrieved out through the umbilical port. Now our next job is to see the uterus, ovaries, right iliac fossa also. So thus again the pneumoperitoneum is going on, and camera person is washing the camera for proper visualization, and white balancing, it is reintroduced. Now the suctioning procedure and irrigation procedure is going on. So we are irrigating it with the help of the ringer lactate solution, and you can well appreciate that the right iliac fossa can well be visualized. And we are going to see the pelvis. The median umbilical ligament can well be visualized. The medial umbilical ligament, you can now be well appreciate both on the left and the right side. And here the patient's positioning has been changed, 15-degree 10 head down position. And see the ovaries here, the fallopian tube, which is very enlarged, and the ovary is also very enlarged, fallopian tube is engorged. There is adenomyomatosis of the uterus, and the fundal fibroma is there. There is adhesions of the omentum with the fundus of the uterus. On the left side also there is the engorged fallopian tube. The ovary is also very much dilated, and this fundal adhesion of the omentum has to be taken care of because it is the cause of the pain for this patient, and there is adenomyomatic changes of the uterus. So this fundus fibroma that was probably operated initially during the season section creates some scar, and this adhesion will jeopardize the life of this patient. So I am just separating this scar from the fundal attachment, and it is the main cause of the pain because during vibration journey or during abdomen drooping forward, this creates some tractional injury over the omentum and gut. That is the main cause of the pain. So uterus is quite elongated one. You can appreciate that there is a fundal fibroma could be there, and there is also thorough peritoneal lavage is going on with the help of the worm saline, and there is adenomyomatic changes of the uterus is noticeable, and ovaries are enlarged, fallopian tube is engorged here. So pouch of Douglas is thoroughly washed out, anterior aspect of the uterus is properly washed. There is white balance has been somehow changed, so it is again reintroduced and white balance done. So you can well appreciate that there is you can see the appendix here. The appendix is quite normal. On the left side also there is the large ovary, right sided large ovary, and apart from this there is no other adhesions present. So our job is next focused towards the suctioning and irrigation. That is the most important part after operative intervention, because without proper suction irrigation the operation will not be completed enough. So thorough irrigation is the main key, and you can well appreciate the returning fluid is also clear. There is no bleeding at all, and I am just trying to see the clip positions and any small oozing from the liver bed present or not. So our job is almost done, and I will prefer here to apply this omentum into the liver bed, that is the gallbladder fossa within this, and it will take care of the hemostasis, small oozing, and it is the abdominal policeman, so it will take care of anything. So you can appreciate that there is no bleeding, and I am just putting the omentum within this gallbladder fossa of the liver bed. So our job is done. That is quite good. The appendix is also normal, and proper delineation is done, and uterine fibroid could be there, and that has been taken care of. So our job is done. Thanks.